Welcome to this Beyond Zero e-learning module for clinicians on the support of patients with poor adherence to antiretroviral treatment. This is Module 2 of 3 modules on an approach for clinicians on poor adherence in complicated HIV and TB patients. Module 1 looked at the personal factors that contributes to better adherence in patients and how we can strengthen those qualities as a clinician. This module will give clinicians a practical framework on how to explore obstacles to treatment adherence. We are fortunate in South Africa that we have good ARVs in a single tablet formation with few side effects or long-term complications. HIV no longer needs to progress to AIDS and death. And most of the time this is the case, with more than 80% of our patients achieving viral load suppression. But we still see patients presenting with AIDS or deteriorating health and many avoidable deaths. But I can already see clinicians shaking their heads in despair when discussing their ill patients. If only they would take their treatment. She was doing so well until she stopped her treatment. If fortunate, the doctor can refer the patient to the social worker or even a psychologist, but not many clinicians have that option and find that the responsibility of addressing adherence issues lie with them alone. So how do I get my patient to take his or her treatment? This module does not include any clever tricks that will suddenly ensure your patient take their ARVs, but it will provide you with a framework you can use to help your patient in finding a solution. At the very least, it will help ensure that you are not part of the problem. This framework is based on the assumption that your patient wants to get better and wants to have the best health outcomes possible. Healthcare worker and patient have the same goal. We are going to start with an assumption. Your patient wants to get better. He or she wants to have good health. He or she does not want to develop AIDS and does not want to pass the virus on to others. That is why your patient started treatment in the first place. So why does a reasonable, sensible human being behave in a way that might cost him or her their health or even their life? To help you and your patient answer this question, we will use a framework created by Joseph Brenny and colleagues, and it is based on the principles of change management often used in healthcare improvement. It can also help us embark on an exploration with our patient to better understand the underlying reasons for poor adherence. Any patient commencing on treatment needs to make a change in their life. When we are wondering why my patient is not taking treatment reliably, we need to answer the following 2 questions. Is my patient not able to take the treatment? Or is my patient not motivated to take the treatment? The barrier will always fall into one or both of these categories, ability or motivation. We are going to use a structured worksheet to help us have a conversation with our patient to answer this question. The link for the free PDF download of the worksheet will be in the notes below this video. We will look at these areas of motivation and ability by dividing it into 3 levels. First, the personal inner level, then the social or relationship level, and lastly, the structural organizational level. Let us look at ability first. To do something, you have to be able to do it. Personal ability speaks to the knowledge and skill that the person either has or may not have. This includes real practical issues like being able to swallow that massive Alluvia tablet, or the granny drawing up liquid formulations with a syringe for her HIV-infected grandchild, or simply being able to convince her child to swallow the bitter Calitra. A second aspect under personal ability is treatment literacy, and this is well known. Ensuring your patient has all the information they need regarding their management and treatment. The better a patient understands the need for taking regular treatment, the more enabled they will be. But a third aspect under personal ability I would like to include is being aware of the importance of conditions that can make it difficult to remember to take tablets daily. depression, psychosis, and alcoholism are illnesses that massively interfere with a person's ability to take medication. A screen for depression and doing the CAGE questionnaire for alcohol abuse should be a routine part of your assessment. These are some examples of key questions outlined in the worksheet that can be used to identify barriers on the level of personal ability. Let us move on to ability as influenced on a social level. Family, friends, and employers can both enable a patient to take treatment or prevent them. For example, that employer that refuses to grant paid leave for a patient to collect medication, or a partner that throws out the treatment. Don't forget some church retreats or traditional healer trainings that prohibits the participants from taking treatment during those events. Key populations such as men who have sex with men, the LGBTI community, or sex workers may even be refused services at some health facilities. Here are the examples of the key questions on the worksheet on the influence of social ability. Structural and organizational effects on ability are easy to identify and difficult to rectify. Poverty can affect the ability to access services, be it taking time off piecemeal work or paying for transport. Many patients find it difficult to take treatment on an empty stomach. Systems at facilities can be unaccommodating, for example, refusing to dispense treatment without transfer letters, or patients having no after-hour access to pick up treatment. Below are some of the examples of key questions on structural ability included on the worksheet. So we can now answer our first question. Is my patient able to take treatment? Does he have the knowledge, the support, and the structures that enable him to do so? But your patient may be able but not motivated. Motivation is difficult to assess, and it is even harder to identify the root causes of motivation than it is with ability. We will start again with the level of personal motivation. With a high level of motivation, most problems can be solved. If a person understands the value of the treatment, is desperate to get well and stay well, or to keep her baby safe from infection, she will overcome many obstacles on both the ability and motivation front. Health education studies have shown that the better we counsel our patients before we start treatment, the more likely they will take their tablets. But this counseling is not simply giving out facts and figures. The quality of the counseling also matters. As discussed in more detail in Module 1, the patient must understand the treatment, but also feel that they have the power to engage. We need to inspire our patients. But how? According to Schnelder et al., to help motivate your patient, you need to take your patient's health beliefs into account. You need to understand their health. So here are some key questions related to personal motivation. Please note that this is not an interrogation, but an appreciative inquiry. The patient should experience you as being supportive and respectful of their health beliefs. We now move on to the level of social motivation, and do not underestimate the power of this, or more likely, social demotivation. Stigma, lack of disclosure, isolation, and discrimination are all factors in poor adherence. Similarly, having a motivated friend or a family member can make a big difference. Hence the emphasis on a treatment supporter and the importance of disclosure. But don't only focus on the social environment of your patient at home. The clinician has massive power to both motivate the patient and similarly can demotivate. Schnelder et al. Has showed in a cross-sectional analysis with 554 patients that good doctor-patient relationships are associated with higher rates of adherence. So ask yourself the question, do you think your patient would recommend you to others? See Module 1 for more detail on the effect of your own style as clinician and the organizational culture of your clinic on your patient's ability to take treatment. Here we have the key questions that explore the social support around your patient. It also includes some introspection in your role as clinician. Structural motivations talk to systems, processes, or tools that can make it easier and can even motivate patients to take treatment. Prevention here is better than cure. The new focus of the Department of Health, for example, in delivering medication, is an excellent way to ensure patients do not have to spend long days in clinics. Creating simpler regimens are known to improve adherence, and it's important to look at where the fixed dose combinations can be used. For example, using an AZT and lamivudine combination tablet for patients on second line. We still urgently need more fixed dose combinations for our children. Sitting in queues for hours, being told to come back another day to complete a visit, or losing patient records can be extremely demotivating. Here are some examples from the worksheet on some key questions regarding structural motivation. So now we can answer our second question. Is my patient motivated to take treatment? Do they really want to be on treatment? Are those around them encouraging? And do we create easy systems and structures to support adherence? So what's the next step? To be able to use this framework, use the worksheet, sit down with your patient, and together discuss each of the 6 areas of influence. This does not take long, and it will reduce wasted time by preventing you as a clinician proposing interventions or doing counseling on issues that are not relevant to your patient. Your key discussion points will therefore address barriers to motivation and ability on a personal level, social level, and lastly, structural level. Using change management terminology, we can define this discussion around the 6 areas of influence as a root cause analysis, and if done correctly, already becomes part of our intervention. Listening to your patient builds strong relationships and strengthens your patient's self-efficacy. But what is the next step? In Module 3, we will build on this analysis to help our patient develop a treatment adherence plan. Thank you for joining us. Please see the notes section for more information on other modules and downloadable free resources.